Hey guys, we're going to go ahead and go into our next topic, minor oral surgical procedures for pediatric patients. This is going to be another lengthy lecture, so I'll make sure to highlight the key points that you need for your quizzes and exam. So our two objectives is to master key concepts and safety during oral surgery procedures, understanding indications, principles, and purpose of common oral surgery procedures that the provider may perform or refer out for pediatric patients. We'll first start off with extradontia, aka extraction. So indication for extractions would be for non-restorable teeth caries, apical disease, fractures of crowns or roots, prolonged retention of primary teeth, specifically in regards to ankylosis, impacted teeth, and supernumerary teeth. Pre-procedure checklist should include the name and date of birth of the patient, extensive medical history, which tooth, so making sure that you're confirming with the referring dentist, whether that be a general dentist, orthodontist, or fellow pediatric dentist. Confirm with the parent. If need be, you can use an indelible marker to make sure that you're marking the correct tooth. And on any forms, making sure that you're documenting the tooth number and the name of the tooth. So for example, number A, 255, upper right, second primary molar. So be as detailed and specific as possible just to make sure that you're doing the right procedure. You want to also indicate the position of the tooth in relation to subcutaneous tooth and any surrounding anatomical structures. List the risk, benefits, and alternative treatments, making sure it's listed on all of the documentation, and then also making sure that the consent forms are signed before even anesthetizing the patient, administering nitrous, whatever it may be, before you touch the patient. Make sure all consent forms are signed. As far as patient management goes, you never want to work without an assistant when it comes to extractions. You want to make sure that you are preparing the patient. You never want to use any threatening words such as yank or pull out. Make sure that you use nice, calm, soothing words such as wiggle, making sure that the patient knows that, hey, we're going to give your tooth a big hug, things of that nature. You also want to make sure that you're prepared and using gauze so that way you can protect the back of the throat. And then don't pick up any forceps until you've properly luxated that tooth in question. Make sure you use your tactile sensation, so tooth gradually increasing in mobility. So you want to make sure that you use your fingers to ensure that that tooth is ready. Okay, and then you also want to make sure you don't use any type of brute force. You want to be as gentle as possible, so that way you're not breaking any surrounding bone at all, like any buccal plate or anything to that extent when you're extracting the tooth. So here's some of your basic armamentarium. So you have your bite block, you have your tongue retractor, cheek retractors, any soft tissue retractors. You have your surgical suction, your forceps, periostal elevator, as well as your other elevators. In regards to specific type of armamentarium, I tend to shy away from using the pediatric cow horn forceps. I tend to only use it with permanent molars, just because if you think about the anatomy that we spoke about earlier, you want to make sure that you are properly taking care of the permanent tooth bud. If not, and you use brute force, you may end up in a situation like this, to where now you have the permanent tooth bud that's nestling safely where it should be, in between the roots of the primary tooth. But however, utilizing an instrument such as a cow horn that may end up grabbing the permanent tooth bud the same time as the primary tooth can cause an issue like this, and then having to explain to the parent that that child may not have a permanent tooth to follow that primary tooth, especially if you don't catch it. There's some instances where you may end up being able to place that tooth bud back inside of the socket, but you may have to wait to kind of see if that was even positioned correctly to where, corrective type of procedures may be done if that tooth ends up, you know, developing at an angle or things like that. So in addition to the previously mentioned armamentarium, floss is definitely your best friend when it comes to any type of oral surgery procedures. It's best to utilize floss around any type of loose items. So specifically would be like your gauze, cotton roll, or even your mouth prop. You want to use some type of floss so that way your assistant or even yourself can be able to grab that item in case it does go back in the patient's throat and causes some type of aspiration. In regards to positioning of your instruments when proceeding with exodontia, for maxillary extractions, you want to make sure that you are positioned along the maxillary occlusal plane at 60 to 90 degrees to the floor. With mandibular extractions, you want to make sure that the mandibular occlusal plane is parallel to the floor. The patient's mouth should be at or slightly below the dentist's elbow, so you never want to be on your tippy toe trying to do a dental extraction. Okay, and you also want to place the patient in a more upright position, especially if they are sedated. Keep in mind about just the anatomy of a pediatric patient. So the ribs are more in a horizontal position, and they have less developed accessory muscles, so it makes it a little bit more difficult to breathe if the patient is laying flat. So you want to make sure that they are in a more upright position. So in regards to making sure that you are covering your bases during extraction, keep in mind that you want to make sure that you don't cause any soft tissue damage. So make sure that you at least have some type of fulcrum, making sure that you are protecting the buccal plate of that tooth that surrounds that tooth, and that your instruments are positioned in the appropriate manner. So with the first picture, you can kind of see the instruments are more apically, or the instrument is more apically positioned. So that way the operator can successfully luxate that tooth as best as possible before picking up the forceps. If you do more at a straighter, more parallel angle, you may run the risk of that particular instrument bypassing that tooth and kind of hurting or causing damage to the soft tissue. So we'll move on to our next topic of ankylosis. So with ankylosis, commonly you would see it with the second primary molar, and of course that has to do with the development of the periodontal ligaments surrounding that particular tooth. And so with the ankylosis of primary teeth, you can kind of see in these pictures how it is how it appears clinically. So during your examination, you're kind of looking for a tooth that is submerged. If it is submerged, you may want to do some type of test to where you use the end of your explorer and gently tap on that tooth and then the surrounding or adjacent teeth as well, just to kind of hear of a sound difference. So with the teeth that are not submerged, it's more so at a higher pitch when you're using the end of your explorer, and then with the ankylosed tooth, the sound is a little bit more dull. So um, so two things. So with the submersion of that particular tooth, you're going to start to see the super eruption of that adjacent tooth as well. So in that first picture on the left hand side, you see tooth number K, that is ankylosed, and then you're also seeing the super eruption of tooth number 13, so that adjacent tooth. So two things that are happening in this picture as well as in the radiograph. So the reason why that this can be an issue, there are times when you do have a tooth that is ankylosed that does not have a subcutaneous tooth, but in cases where that tooth is ankylosed and there is a subcutaneous tooth, you need to go ahead and figure out your proper extraction protocol to go ahead and remove that ankylosed tooth. What ends up happening is the subcutaneous tooth does not have room to push out the natural way, that upward motion, so it tends to drift and slide into a position to where it feels like it can push up, but then it's locked in place with the surrounding permanent teeth. And then with the submergence of that primary tooth that is ankylosed, because as the jaw is continuing to move forward and downward in terms of growth, that tooth is going to become more and more submerged. And then the surrounding teeth are going to kind of tip in position to meet each other, and then you're more in a complicated position, and at that point I would refer over to an oral surgeon to move forward with that procedure. So with the difficulty of trying to extract a ankylosed tooth with just the traditional approach, you may want to go ahead and add in utilizing a surgical handpiece. So the surgical handpiece kind of moves at a higher power than your regular handpieces, and it also utilizes a long diamond burr just so you can properly position the burr into the sulcus and go ahead and create more space surrounding that tooth. So that way it's easier for you to luxate that tooth and be able to extract it properly without causing any further damage. So yeah, so with that burr, you cut circumferentially, I guess at the expense of that tooth. Okay, when it comes to third molars, three things to consider. Um, there are some, I guess, some hesitation, depending on what type of specialist you speak to in regards to third molar extractions. In some cases, prophylactic extraction of all impacted or partially impacted third molars is not appropriate. There's some that do believe that the lack of scientific evidence to justify indication of the prophylactic extraction of third molars, and then also extraction may be indicated if caries present or if periodontal disease develops. So just because a person has their wisdom teeth fully erupted, if it doesn't have a cavity or if it's not causing any underlying periodontal issues, you can definitely leave them in place. But yeah, if pain should subside or facial swelling appears, or even with ortho, if there's some type of crowding issue that's going on, the orthodontist will then let you know if they would like the third molars to be extracted. So that way it's a team approach and everybody's on the same page. So with impacted canines, the best result is when the tooth is almost completely formed and the apex is not yet closed. So that's when you want to go ahead and surgically remove it. Impacted canine can usually be palpated. So you want to go ahead and feel around when you're doing your clinical examination. So just make sure that you're doing thorough clinical exams. So with the procedure itself, you want to go ahead and do a full thickness flap. You want to remove any underlying bone and any bone impeding the eruption path of that tooth. You want to chisel that away, or you can use a surgical handpiece that I showed before. You want to then attach an orthodontic bracket with a gold chain to apply a pulling force in the direction of the eruption that you're seeking. Now be careful when you're using gold. I know it's a rare allergy for some people to have, but there are some that do have it. So make sure that you have that thorough medical history on file when you're asking about allergies, so that way the patient doesn't get irritated with that gold chain. So here's basically a visual of the procedure that I just talked about. So the full thickness flap, go ahead and chisel away any underlying bone or use a surgical handpiece so that way you can expose the canine. And then go ahead and attach that gold button. And then as you can see, the patient is in orthodontic treatment, so it's easy to attach the gold chain onto the orthodontic wire. So soft tissue procedures, the first we'll talk about is a labial frenectomy. So with this particular patient, they have a 6 millimeter diastema between 8 and 9, and you can kind of see they have a very thick maxillary frenum. So with that, you want to go ahead and let the parent know that you do see that this is an issue. This is the reason why the patient may have this gap. If we go ahead and maybe fix it orthodontically, it can then end up reverting back because that underlying tissue is still there. So you want to go ahead and remove that. So the frenum itself is a fold of mucous membrane that consists of connective tissue with elastic and collagen fibers, and at times muscular fibers originating from the orbicularis oris that attach the lip and the cheek to the alveolar mucosa, the gingiva, and the underlying periosteum. So this particular structure contains vascular structures with thin peripheral nervous ramifications and is covered by stratified layer epithelium. So all that to say, it is a very thick attachment that can basically bring multiple components of the mouth together. That makes it very hard for the teeth to naturally come in place. Okay, according to AAPD guidelines, it states that the maxillary frenum is a dynamic structure, so an immovable structure, or actually, it's a structure that presents changes in position of insertion, structure, and shape during growth and development. So it's not a immovable, like a static structure, but it's constantly changing and moving to the point where it can go ahead and move around the dentition and cause different changes within the mouth. So as far as classification goes, we know in dentistry, you can't just have something without it being classified in some kind of way because there's varying degrees of that particular type of issue. Okay, so with the class 1 type of frenum attachment, we see that the insertion is at the mucogingival junction. So it's more involving of the mucosa. Class 2 involves the gingiva, it extends to the gingiva. Okay, and then the abnormal anatomy, more so with class 3, it involves the papilla. So the attachment inserts itself between the teeth around the papilla. And then with the class 4, the papilla is penetrating. So insertion is at the level of the vestibular or at the palatal papilla. So that would be the previous picture that we saw. So based on the guidelines, there are differences in treatment recommendations among medical providers, which include the pediatricians, speech pathologists, surgeons, lactation consultants, speech pathologists, even dentists. So basically, you always want to approach things in a team format. But when it comes to a frenectomy, there are varying opinions in regards to whether or not to proceed with that procedure. So clear indications and timing of surgical treatment remains controversial due to the lack of consensus. So things that you may want to consider as a healthcare professional, you want to make sure that you're looking at determining the degree of the restriction and relative impaction on growth, development, feeding, or oral motor functions, including speech. So with development. So with the primary teeth, if you see a diastema, you may not want to do something right away. You want to wait until you can see the permanent teeth and see if the diastema will still present itself. Even in that particular case, you may want to end up waiting until the permanent canines erupt and seeing if closure follows with the eruption of the canine. If it does not kind of alleviate that space, then you want to maybe move forward with doing a frenectomy. And then even with lingual frenectomies in regards to speech, you do have some cultures to where certain functions of the tongue need to come in place, especially if the patient is Hispanic and being able to roll their R's is an issue. You may want to go ahead and talk to the parent and move forward with that lingual frenectomy. And we'll see pictures of that later. So I know this is hard to see, but just, a couple of oral and dental clinical indications. Oh, and with feeding, sorry, let me go back to this. In newborns, it may be indicated due to poor breastfeeding, so you want to proceed with that frenectomy. And we talked about relapse when it comes to post-orthodontic treatment. And as far as guidelines go, I know this is a wordy slide, so I'll kind of just point out the key things. So the second point of bite treatment is suggested when the attachment exerts a traumatic force on the gingiva, causing the papilla to blanch when the upper lip is pulled. So you want to do a blanch test. Or if it causes a diastema wider than 2 millimeters, so the first picture that we saw was 6 millimeters, which is known to rarely close spontaneously during further development. So important to manage the diastema and its etiology. If orthodontic treatment is indicated, the need for frenectomy should be assessed and coordinated with orthodontic closure of the diastema to achieve stable results. All right, so midline diastema. So basically the definition is the space or the gap between the maxillary central incisors, okay? Can be a normal growth characteristic during the primary and mixed dentition. So during the ugly duckling stage and mixed dentition, you may see that gap because the maxillary teeth are a little bit more splayed out. Etiology or epidemiology, excuse me, reduces with age from 98% of 6-year-olds, 49% of 11-year-olds, to 7% of teenagers. Remember the ethnic norms, so you see a greater occurrence in Africans and Mediterranean whites. A lot of the times the parents have no issues with the gap or diastema because it's just culturally known that, hey, everybody in the family may have it, so they may not have an issue with it. But you have to make sure that you're letting them know the pros and cons of having that, and then moving forward with anything outlined in the treatment plan. As far as surgical techniques for the midline diastema frenectomy, there's 4 different types of surgical techniques, but we'll just talk about one, which is the classic one. The other 3 have to, be done by a specialist. So more so like not ortho, but oral surgery, or sometimes the periodontist may do those types of procedures as well. So with the conventional or classic technique, founded in 1960, so basically the frenum or interdental tissue is completely excised, and frequently results in an unacceptable aesthetic result, so a darker space between that area where the tissue was excised. So you may want to warn the parent in regards to that. And it does heal by secondary intention, so there will be some scarring. So continue to monitor and have some post-operative visits as well. So with the classic technique, this is a case that was done by one of my colleagues. So this is patient LP. They went ahead and excised the tissue between 8 and 9. As you can see, it was more so of a class 4 type of frenum attachment. They removed any underlying tissue as well, so that way reoccurrence does not happen. So post-operatively, this is what patient LP looked like. This was done in the OR, hence quadrant dentistry, and the whole full mouth dentistry was done in this case. And so with post-op care, you want to make sure that you leave on the periodontal dressing for 1 week. So making sure that the parent knows to not have the child play with it or irritate the area, so that way you can have optimal healing. You want to go ahead and avoid any type of spicy, hot, or sour foods. Warm salt water rinses for at least a week, and then removal of dressing in a week when you do the follow-up appointment. And then you'll do a 1 month follow-up as well, just to make sure everything is going well. In the case of patient LP, no sutures were placed, no periodontal dressing was placed, and it did heal by secondary intention. So this is what it looked like at the 1 week follow-up. And then this is what it looked like at the 1 month follow-up. So you can see that the frenum attachment is a little higher up into the vestibule. And then follow-up treatment orthodontically was done on this patient to increase or decrease the space between 8 and 9. Okay, so frenectomies can be done in multiple ways. You have electrosurgery, which is basically done with a laser in a sense. So it's minimal procedural bleeding and faster cutting. There's no sutures that are needed. Recommended for patients with hemostatic problems, so any type of blood disorders. Minimal post-operative pain. And then special eyewear is not really required for this type of procedure than it would be compared to laser treatment. So electrosurgery is not laser treatment. Let me clarify myself. But it definitely is faster in cutting than the traditional method with the scalpel. And then healing is also by secondary intention, which may result in scarring. Due to heat, no anesthesia is necessarily needed. And then you do have issue or caution when it comes to combustion hazard. When it comes to lasers, they are higher precision compared to the surgical tools. Somewhat painless procedure. Severe cases may necessitate topical or local anesthetic application. Less bleeding, swelling, and scarring, so no need for sutures in this particular case. Easy to use, decreased surgical time, less risk of post-operative infections. It does require training and some certification for sure. Purchase of laser and protective eyewear is definitely needed. So it's not your conventional eyewear that you wear in a clinic, like the clear plastic. There is like an actual eyewear that you need to buy in order for you to utilize this. All right, so labial frenectomy, as you can see in this particular case, this frenum attachment is causing a diastema and also gingival recession associated with tooth number 24. So they went ahead and did it the traditional way and removed that tissue there, sutured the area, and as you can see, it's healing. And then the last photo, you can see where it was resolved, and the diastema actually closed between 24 and 25. Lingual frenectomy. So with this procedure, it's the removal of the lingual frenum, requires removal of attachment to bone as well. So that's make sure you keep that as a note. Indications, localized gingival recession, ankyloglossia, speech pathology. So if they've gone through speech and it still has not resolved, you may want to go through and do that lingual frenectomy. Alternative for babies having difficulty with breastfeeding is a frenotomy. So you're clipping the frenum without attachment dissection from the bone. Okay, so you don't have to really consider bone when you're doing the frenotomy. And so with the lingual frenectomy, this is a more conventional approach. So you're tying a piece of suture or string around the tongue to lift the tongue so you can expose the frenum attachment that's there. Go ahead and clip it with a surgical scissor. You want to make sure you go through and kind of excise a little bit of the muscle in the underlying tongue, so that way you don't have reoccurrence and the muscle attachment does not go back in the same place. Then consider post-operative stretching when it comes to a lingual frenectomy or frenotomy, and then we'll go into a video that kind of helps us to see what that looks like. If the video does not play, I'll go ahead and send this to you guys at a later date. Okay, so basically you're doing an upward motion. Okay, so you want to educate the parent and let them know that it is an upward motion, and that they're constantly going to be doing that for at least 4 to 6 hours for about a week or 2 weeks, so that way optimal healing can occur in that area. So I kind of use that video as an educational tool for a lot of my parents after we do the procedure, just to let them know that this is what I expect. And I do give them a handout as well to let them know how to go about that. Okay, so this particular procedure, definitely keep note of it. The supracrestal quest crestal, excuse me, guys, fibrotomy. So this orthodontic rotation occurs of the tooth stretch of around the tooth, and it stretches the gingival attachment around that tooth. The stretch fibers can cause relapse after rotations have been corrected. When ortho almost is completed, the supracrestal fibers cut with a 12B blade under local anesthesia. So basically, the way that you want to correct this after ortho treatment is completed, you want to go ahead and cut those fibers so that way the tooth does not rotate back into the position pre-ortho. Okay, gingival fibers will reorganize and reattach in new position. Okay, so you're using a 12B blade. Okay, so this is done post ortho, things to keep in mind. And just remembering that orthodontic rotation is what happens when this fiber is not in the right place. So it repositions the tooth in a position that we don't want it to be. So when a patient sees this, they're always asking, am I going to die? Any type of abnormal growth, a lot of the times a layperson is thinking some type of cancerous growth. So you want to be able to know and recognize what this particular lesion is, and it is a mucocele. So we'll talk and let you know what a mucocele actually is. So it is a common salivary gland disorder that can appear in the lacrimal sac, perinasal sinus, oral cavity, appendix, or gallbladder. So it is not limited to the oral cavity. These lesions occur due to mucus accumulation resulting from the alteration of the minor salivary glands. That's an important thing to note. Lower lip is the most common site of occurrence of these lesions in the oral cavity, and most probable cause is trauma. So if a patient is constantly biting their lip all the time, and then mom or dad notices that they have this growth, patient's probably not even aware that they've been biting their lip, and they bring them over to you guys to take a look, and you ask, and they ask you, how did this happen? And then you just ask, like, hey, little Johnny or Susie, have you been biting your lip, like, without even noticing? Or did you fall at some point? Like, yeah, I fell, like a week ago, and then all of a sudden this popped up. And then, so you kind of have your history with that. Okay, so with the mucocele, treatment options include surgical excision, marsupialization, micro marsupialization, cryosurgery, laser evaporation, and laser excision. Okay, surgical excision requires removal of the associated minor salivary glands. So please remember, if you're going to proceed with this particular procedure, that you remove the associated salivary glands. So they kind of look like little bitty tiny grapes when you go in and excise the area. So you already have this middle portion, like in picture B, where you have that sac that's there, you want to go ahead and remove that, but you also want to use your surgical blade and kind of brush through that area to remove any of the salivary glands. So, implants or no implants, especially in pediatric patients. So, when you're looking at this picture, this patient looks like they are in full permanent dentition. So, at that point, you may want to question, like, hey, whatever happened to the laterals? Make sure that you take your clinical photos and your radiographs just to make sure that you are documenting the case throughout. That you can kind of let the parent know that we've never seen the laterals in any of the radiographs, so we need to then consider and plan for implant in the future. So things you need to look out for. You need to confirm whether or not that patient is still growing. So you want to use a cephalometric type of radiograph, and you're looking at the spine itself, just to see if the bones are still growing. Okay. Um, even if growth is no longer continuing, changes in facial morphology can still occur for several years. So you may want to delay implants with alternative fixed or removable prostheses as an option until that patient is done growing. So these are two clinical cases that I'm going to briefly go over with you guys. So this is patient AJ. Mom was noticing that her teeth were kind of shifting. They were first straight, and then all of a sudden 8 and 9 just started moving gradually over time. And so we went ahead and took a radiograph, and then also we did a CT just to kind of see what was going on in that position. So it turns out after we examined her radiographs in other images, we noticed that she did have supernumerary teeth or odontomas associated with tooth number 8 and 9. So in the OR, we went ahead and did a full thickness flap. We used our surgical handpiece to kind of chisel away at the underlying bone. We went ahead and exposed that area, and as you can see, there's one odontoma there. We thought that there were only 2, but as we're continuing to excavate in that area, we saw that there were multiple that were in there. So we made sure that we verified that we removed everything, and then we packed the area with some bone, and then we covered everything up and sutured her. And then it took her about a month or so to completely heal, and then everything was kind of back in its place. And so this is what she looked like post-operatively with the sutures in place. And she was like an amazing patient. Okay, and then this is patient VS. She was 3 days old when she presented to us at first. And then mom was concerned. We told her, come back in a month, so that way we can kind of see if she's developing a little bit better, if maybe feeding has gotten better. And no, it didn't. So we went ahead and scheduled an appointment to do a lingual frenectomy. So mom kind of fed her a little bit before, as much as she can actually take through the bottle. She wasn't breastfeeding well. As you can see with her sticking her tongue out, she kind of has that little heart shape at the tip of her tongue, which indicates how extensive her ankyloglossia is. When you lift the tongue, you can kind of see that little piece of tissue, the frenum attachment that's there. So we went ahead and used a laser, a diode laser, and we utilized some saline solution to go ahead and keep the area moisturized. And we used what we called a groove director to retract the tongue. And we used that laser diode to go ahead and remove that tissue. So with this particular patient, we didn't use any local anesthetic because we didn't want to run the risk of methemoglobin anemia, to where that particular local anesthetic can run into not allowing her hemoglobin to release the oxygen into her system. So we didn't want that to be a problem. So we just used a topical just to numb the area. And of course, she was crying throughout the procedure, but that's okay. We got it done, and mom was happy at the end. and she was able to feed her right away. So she took to the bottle and she basically drank half of the bottle when normally she only drank a third. Okay, and this is what it looked like post-operatively. So this is where you want to go ahead and give the parent some instructions as to what to do with the post-operative exercises to make sure the patient obtains optimal healing. And that's it. Thank you so much for your attention, everyone. I know that was a long lecture. Email us if you have any questions.